start the session now. It's 1:30 and we will try to stick to the time. So welcome to everyone who have joined here. So today's IC will be on dealing with disguise, masquerades in ophthalmic oncology. Over the next 55 minutes, we will try to cover the masquerades involving various tissues from the eyelid, conjunctiva, intraocular tumors, and orbit. With me, I'm Dr. SWATHI KALIKI. I work at Rp Eye Institute, and with me I have my co-instructors, Dr. Prerna. She's from Mumbai, and she works at the Mumbai Eye Plastic Surgery Services. And there's Savri Desai, who is in the audience, and she's about to join us here. So she's also from Mumbai, and she works at Hinduja. And has been doing plasty for more than a decade here. And also we have Dr. Vijita Vempuluru. She has been a fellow at Rp Eye Institute. She completed her fellowship and she's about to start her oncology fellowship with the Shields next month. So thank you everyone for joining. First we will start with the eyelid tumors, and I request Prerna to talk about masquerades in eyelid tumors and eye out for eyelid tumor.
Good afternoon, everybody, and especially a warm welcome to everybody who decided to bunk the quiz and listen to this really, really interesting session. I promise you will get quite a bit out of this, and it will be a big different it will make a big difference to your practice. So thank you, Dr. Swati, for inviting me to this interesting symposium. Basically, my talk is to discuss a couple of masquerades or masqueraders of eyelid malignancies. So while I was contemplating on what to speak about this topic, I've kind of distilled to giving a lot of clinical signs and information and cut out on all the fancy treatment options, so that everybody can use this back in their clinic. All good. Okay, great. Perfect. So before we start, I'm starting with this gentleman. He's a 63-year-old male who presented to me with a persistent nodule over the left lower inner eyelid since the last 2 years, and he's had 4 surgeries done for the same, for this persistent chalazion. Does this raise any kind of red flag in your mind? What do you think? Something looking as indolent as this. It's just a small nodule at the inner corner which looks typically like a chalazion except for that one blood vessel over it. So what ideally you would want to do next is at least a thorough clinical evaluation. So on eversion of the eyelid, what I could clearly see was, so the blue mark over here, the arrow, is the normal meibomian gland openings which are whitish dots, and suddenly medial to it over the mass you see that those openings are lost. There are blood vessels crossing over to the mass, so these are feeder vessels, and the star marked is something I want you to focus on. So a chalazion can be cystic and it will elevate the conjunctiva over it, but this star mark is a demarcation that on palpation was firm, which was showing that the mass is actually infiltrating laterally also into the tarsus. Even on gross examination over the skin, the reddish area that I've marked is the infiltrated part which appears as thickened eyelid over there. So what looked like a chalazion had all of these features of loss of glands, but the most alarming sign here is something that's been operated 4 times for chalazion elsewhere should ideally be biopsied. So even if it's a chalazion that's come back after one surgery, ideally you should have your flags up and a low threshold to biopsy it. So this came out to be a not so poorly differentiated sebaceous gland carcinoma that was also invading into the conjunctiva around it. Similar case scenario, a very young lady, she's only 48 years old, who presented again with a persistent chalazion. So this is another case scenario where you evert and you see what looks very placid with yellowish nodules over it, goes into the tarsus and is covering the eyelid margin as well. Ideal case scenario for sebaceous gland carcinoma would be do an incision biopsy, and based on the extent you can even take more samples from around called map biopsy. Do a whole body PET scan with wide excision treatment under margin control and reconstruction, or first you downsize the tumor with chemotherapy. Based on the histopathology, you may need adjunctive radiation. The reason I'm starting with sebaceous gland carcinoma is because that's the one that we see most commonly in our Indian case scenario, and there's not enough literature in the West to support what we see over here. So when you get these kind of cases that are masqueraders, instead of just blindly going in and going with the first feeling that you get that maybe this is a chalazion, it would be ideal to be cognizant of what features are normally seen in suspicious lesions. So when you have destruction of eyelid architecture, as in these cases, loss of eyelashes, telangiectasia, intrinsic vascularity, nodularity with everted margins, ulceration, bleeding, effacement of all the meibomian glands or tarsal thickening, your radar should be really high up there. Going to a second case scenario. Now this is a 67-year-old female. She was treated elsewhere for blepharitis. So you definitely see the right eyelid and you see some irregular thickening here. What else do you observe grossly, which needs a little fine eye? See the lid creases over the skin on the left eyelid and see the ones on the right. They are stretched. That signifies some kind of induration or infiltration. On eversion, what I found was a very typical clinical sebaceous gland carcinoma with yellowish edges over there going into the tarsus and extending beyond. Luckily, this was still localized, so she did well with a wide excision treatment and reconstruction. But some patients may be referred very late into your practice, and these conditions can offer morbidity, cause mortality, as well as the risk of metastasis. So we have to be very aware of these conditions. Going to another patient who came with ptosis and blepharitis. Now again, if you look at this droopy eyelid on eversion, what I found was a very typical papillary variant of something that we call as a squamous cell carcinoma. So this is how it looks. Not all the cases come on the skin side. Some of them actually come on the conjunctiva and may not even have keratinization. So it was being treated elsewhere as blepharitis, which was probably because of infection. That's what they thought, and that could have led to the ptosis. So he did well with a Cutler bed and is doing well at 2 years follow-up also. This lady came to me with thickening of the phonics and a nodule on the eyelid. On eversion, you see that there is the alteration of conjunctival surface. There is a papillary area over here. There is some variation in texture and induration. There's a mass in the phonics sitting over here, which is extending right from the eyelid margin and creeping onto the bulbar conjunctiva with raised epithelium. So was this really a papilloma or squamous cell carcinoma? So the earlier surgeon had referred thinking that this could be a papilloma and will do well on therapy. So on incision biopsy, there was a papilloma area and an invasive squamous cell carcinoma as well. And this lady is doing well. After 2 cycles of subconjunctival interferon, I decided to downsize because on MRI there was no extension into the orbit, luckily. And then she underwent a wide excision surgical resection. Similarly, another elderly male who had presented with a suspicious lesion, but here some telltale signs are there. You see that there is some loss of architecture. This whitish plaque I want to highlight is nothing but keratin. So this keratin made me really want to evaluate him further and biopsy this area, and it turned out to be an invasive squamous cell carcinoma. So though there was no loss of lashes and there was less intrinsic vascularity, but there are a couple of signs that should make you aware of these conditions. Now going on to a late presented case, this was again missed by some physicians and was being treated as blepharitis. Unfortunately, by the time this patient came to me, the mass had extended. It was an invasive squamous cell carcinoma, had extended into the orbit. So the crusting that you see on the lashes should make you look at all the surface as well, and had to undergo an exentration. Some of the sebaceous gland carcinomas and squamous cell carcinomas are known to spread over the surface along the epithelium, what we call as pagetoid spread. So in these cases, just an incision biopsy may not help. You want to know the extent. So you would want to sample a bit of all the areas. Coming to another very rare case, actually, this is not a common case. So this patient was being treated for over 3 years as multiple hydrocystomas. He started off with an upper eyelid lateral corner with a smaller cystic transilluminant nodule, and by the time he came to me, he was like this. So what do you think this is? This is an extremely rare tumor which usually comes out of the salivary glands, very rarely out of the lacrimal gland. It's a mucoepidermoid carcinoma of the eyelid. By the time he had reached me, I explained and counseled him about the prognosis of the condition, but he was lost to follow up and he refused treatment after this. So what are these eyelid masqueraders and why should you know about these? Basically, any malignant eyelid tumors which present with signs that make you think that maybe these are benign conditions, most commonly as chalazion or blepharitis, sometimes as cysts or papillomas. These could have underlying malignancy, so look out for the suspicious signs. Why should every ophthalmologist know about these? Because the management and prognosis will differ based on when you refer them to an oculoplastics or a super specialty center. The suspicious signs, I've already shown you the slides, and you should always have a low threshold for biopsy. It may come out to be non-malignant, but always biopsy them. This is our last trivia. So considering this is masquerade, sometimes benign conditions can masquerade like malignant. So this is a 1.5-year-old child who presented with this eyelid nodule. And this was there on incision biopsy. Any takers for this? What are these cells? So these are Touton's giant cells which you see in juvenile xanthogranuloma. The biopsy had not taken from the eyelid. He had similar lesions on the neck and the back. So that was biopsied. So these patients do well with intralesional steroids. You need not go ahead and think it's a malignancy and go all out. Similarly, this last case, this turned out to be a pseudoepitheliomatous hyperplasia. And the sign which told us this, or the risk factor, was he was seropositive. Thank you.
Thanks, Prerna, for a very interesting talk and also sticking to the time. Thank you. We'll take the questions at the end. We have last 10 minutes for the questions. Now we have Savri Desai, who will be talking about the subtle signs in surface tumors.
Okay. Thank you, Swati, for inviting me for this talk. And it's good to have people in the audience. And hopefully, in the end, we can all learn from each other. I think Prerna covered a few of the top, not all, but just started off the whole sentiment of how we can pick up certain things. So why like subtle signs, and what is the purpose of subtle signs? So the whole reason for picking up these signs is to diagnose it a little earlier so that we may be able to pick up pre-malignant lesions, to prevent deeper and wider spread, which requires more destructive surgery maybe, and to try and have a more conservative approach so as to be able to not have to go to that level. Also, I think that subtle signs are important because instead of just labeling one thing as just, oh, it could be a pterygium or something like that, it allows you to think and say, okay, it could be something else before the patient moves around to 10 places and comes back with a stage where it's sort of beyond repair. So ocular surface tumors are just broadly classified into epithelial, stromal, caruncular, metastatic, secondary, which are further classified into non-melanocytic and melanocytic. So the way we teach the residents is that just like we document corneal cases, we document our conjunctival tumors and eyelid tumors, in which even she showed some very good tumors where location is important in terms of the interpalpable surface being one of the most common areas because it's exposed to various type of lesions, also the limbus. But also we need to look at the phonics and the tarsus, and those are sometimes have lesions which really give off the subtle signs and give us a clue when I'll show you some cases. then mobility or fixity to the underlying structures, consistency in terms of whether it is puck-like, thick, cystic, thickness, color, which gives a very good giveaway, and also the type of vasculature we see. So the simplest thing we can start with is these lesions, which are commonly seen, especially in our population or our race, which are these small whitish-looking frothy lesions, often on the nasal and temporal aspect. Maybe a little triangular, but not really whitish. They have a subtle pale, sort of yellowish appearance, and if you look, they don't have anything what we call as feeder vessels, no vessels inside the lesion known as intrinsic vessels. Just they're sitting there, and basically some of them usually can be mobile, or some may have little episcleral fixity and are often bilateral, not just nasal and temporal, both eyes. So this is nothing but actinic keratosis. However, the important thing to take away from here is that actinic keratosis can lead to something. So you need to draw it and mark the vertical and horizontal length. So we encourage all residents to mark exactly, besides just taking photographs, so that you can immediately look at it and evaluate it. Coming to this lesion, a little away from the limbus, pedunculated, red, angry looking tortuous vessels, but not what you would call a dilated or a feeder vessel. It's just vessels all around it. So this is a very common condition we see. That's biogenic granuloma. Biogenic granuloma actually don't have any preference for location, and that's also one of the subtle signs that you will find may be associated with some history of subtle trauma or an insect, and will have a short and rapid history. Coming to another bilateral lesion is seen in this patient. He was a farmer and had lesions in both, which he felt had grown. But actually, if you go to see and you see close, there are again no feeder vessels, but what it had is a very fibrovascular frond which was encroaching on the cornea with a little bit of patchy appearance. So this is actually nothing but pterygiums in different stages that we are seeing. One is partially atrophic, one is a progressive pterygium. So often if they have a doubt, we do send these across to each other. Cornea sends it to us, so we send it and we just rule out. And it's always better to be sure that it is a pterygium than to err on the side and say that, oh, okay, it's not a tumor, and just go ahead and ignore it. So now this is a very interesting 40-year-old gentleman who had been following up with me for this lesion, and it was much smaller. So it was a well-defined lesion. Then over the last 2 years, he started having a few of these prominent vessels, and one here, as you can see, but still a little bit of encroachment on the cornea. But there was nothing else, which we'll come to, that suggested that I needed to do anything about it, till he came literally in Jan this year with this change, showing some more prominent feeder vessels and a slightish whitish change. This was a change to basically keratin. So this was a lesion which we had diagnosed as actinic keratosis, and specifically it showed that it had changed. There was furthermore encroachment with these little tongue-shaped lesions going into the cornea. There was episcleral fixity now. So this is something we had been documenting by drawing and on photographs. So since we picked it up early, we did not do a biopsy, but put him on topical interferon, and he's actually already done 2 cycles, and it has regressed, and there is no more keratin. So this was an OSSM. Now this was another person who came to us, was referred by my nephrologist, and said that he's been complaining of these whitish lesions. So, and you can see it's just a sort of linear lesion which is there with not really dilated vessels, but when you look up close, and when I stained him, he had these fine punctate stains on rose bengal. So that even alarmed me, because it was looking suspicious till we stained him on the other side, and we got fine and like proper punctate staining on the lesion. So he was a renal transplant patient. So one of the other things is, if you see multifocal lesions, which is more than in one area, and they are immunocompromised or are transplant patients or on immunosuppressives, this is something that should be immediately you should consider. And we often get these because we have a transplant department in our hospital. So they now know that if there's any lesion on the eye, it has to come to the ophthalmic department for review. So we actually didn't put him on topical. He wanted surgery, and we actually did an excision and followed the protocol for surgery. So OSSN, as we know, these are very frank OSSNs, which are leukoplakic, gelatinous, papilliform, and I've taken some of these are mine and some are taken from LVP from Dr. Hunavar. And there is actually not much to be said about this. The ones which have exuberant keratin it's like a brainless thing that you mostly know it's an OSSN, and there are various managements for OSSN, which we will not be going into. But these are just the different forms, which are not really subtle, but these are things that, this is the various ways they present. Now coming to a lesion like this, which could either be on the bulbar conjunctiva, when we talked about location. So this is not the same patient, but there was one on the eyelid, and he came saying that it had, one was a young adult and one was an adult. Same kid had a recent history, but they're not that, they don't grow like within a few days, but they have this kind of, flower or like papilliform sort of appearance all bunching together, and they may have a few feeder vessels. So these are basically papillomas or squamous papillomas, and often they can even be near the limbus, but they have such a characteristic appearance that you cannot miss it. So just to say that feeder vessels are not diagnostic. Feeder vessels can occur in even 30 to 35% of non-malignant lesions. So coming to this is a patient who had been going around for unilateral blepharoconjunctivitis with diffuse redness and was not resolving. And finally, like Prerna said, this basically did a small map biopsy. This is a map biopsy which I had done, and it turned out to be a diffuse squamous cell carcinoma. So this is something that you must think about, especially when the patient consistently keeps complaining that no matter how much topical treatment you're given, there's no improvement. So coming to cornea, these often present as, corneas are very rare, less than 1% OSSNs, but they'll present as a scar, but they have a typical fimbriated appearance, and in Roche, this is a scar while this is an OSSN, and they're elevated. Sorry, I'm running a little short, so I'm going to quickly rush. So coming to the pigmented lesions, this is, slate gate pigmentation. Most of you all know it. It's oculodermal melanocytosis. The only thing that you need to know is that they have a risk of uveal melanoma. So that is something. You also need to look at the hairline also to see if there's any pigmentation, which you need to rule out any CNS melanoma. And types of melanosis. So the one on this, which is bilateral and diffuse and patchy and doesn't have any significant pattern, is complexion-associated melanosis, which is the current term, but you can call it racial melanosis. And of course, primary acquired melanosis. Now, primary acquired melanosis can be with and without atypia. And the ones with atypia, which is a histopathological diagnosis, is the one that can have a chance of turning to melanoma. So the subtle sign here is that if you see a pigmentation which is in the Phonics, which is plaque-like and thickened, you can, if it's less than, say, maybe 3 clock hours or 10 millimeters, then you may want to observe it. If you're still not sure, then you may want to excise it. This is another nevus, but I'm just going to go to the next one. So this is a mixed appearance. It's a conjunctal nevus. But the reason I put this photo here is because it has cysts, it has intrinsic vessels and subtle feeder vessels. So there can be a overlap of certain subtle signs where you may think that it could be either a pre-malignant or a malignant lesions. However, this was a conjunctival nevus and was excised just for cosmetic reasons. But these are some of the subtle signs that you need to look into. I'll just ignore this. And the last one is a salmon patch sort of appearance, which is basically a lymphoma. And you want to see that you don't mix it for episcleritis. This is basically malt lymphomas, which can be treated and have excellent prognosis. So basically, look for the subtle signs and document what you see, chronologically, because a lot of times when you go back, you find there are changes. When in doubt, in review, and always follow up with your pathology. Thank you. Sorry, I took 1 minute.
Thank you, Savri. I'm sure most of us now understand what are the subtle signs that we have to look for in conjunctival lesions. Thank you.
So next we have Dr. SWATHI KALIKI. She actually needs no introduction. She heads the Ophthalmic Plastic Surgery and Ocular Oncology services at LV Prasad, Hyderabad. She's trained at LVP herself and at Wills Eye Institute. So she'll be talking to us about OCT and the use of OCT in intraocular tumors.
Thanks, Prerna, for the introduction. And so, as Prerna already mentioned, I'll be talking about one of the most useful investigation in intraocular tumors, that is the optical coherence tomography. Now, I'll be taking you through different case scenarios to help you understand how OCT can really help us in arriving at a definitive diagnosis in most cases. Now, this is a 55-year-old female who presented with diminution of vision in the left eye for the past 9 months, and there was a history of cataract surgery in the left eye 7 months back. The best corrected visual acuity in the right eye was 20/20, while in the left eye it was PLPR. The IOP was high on the left side. And there were other features of inflammation that were present in the left eye, including the corneal edema and the keratic precipitates that were present. And there was dense vitritis. There was no further view of the fundus that could be noted. And this was the B scan of the left eye, where we can see that obviously the vitreous is not anechoic. There are membrane echoes that are present in the vitreous. And with this, the patient was diagnosed to have, because there was already a history of cataract surgery, the patient was diagnosed to have chronic endophthalmitis, probably of fungal origin, and the patient underwent the vitreous surgery. And 3 weeks later, the vision was better in the left eye, but the fundus still continued to have the vitreous haze. And at this point of time, there were snowball opacities that were present inferiorly. And the specimen was sent for microbiology, which showed no organisms. Now, the next 3 years, the patient was treated as chronic endophthalmitis, received multiple antifungal injections and the other treatment that is necessary for the same. And the best corrected visual acuity, it was okay. It continued to be at about 20/80 at last follow-up. And then the patient was lost to follow-up. She came back 2 years later, and her vision in the right eye also had dropped at this point of time, where it had become 20/100 from the previous 20/20. And left eye vision had deteriorated from 20/80 to where she began with, that is PLPR in the left eye. And this is the picture of the right eye fundus. At the first visit, the right eye was absolutely normal, but now after a duration of almost 5 years, the fundus picture was this in the right eye, where we can see that there are creamy yellow lesions that are present in the fundus. And this is the OCT through the image, through the lesions, where we can see that there is definite sub-RP deposits that are present when the OCT passes through these lesions. And the left eye, it was very hazy. There was no good view of the fundus, and there was nothing that could be commented on whether there are any lesions that are definitely present in the retina, except for the vitreous having a haze. So at this point of time, it was thought that she had both eyes endogenous endophthalmitis, and the patient underwent vitrectomy for the right eye this time, and various other investigations were done. And this is the sample. It was sent for cytology, and here there were just a few cells that were noted. There was nothing that was thought to be significant. CD20 was faintly positive in some of the cells, and the cytology report was given as that it is probably a reactive process, probably an inflammation. And at this point, PCR also was done of the sample, and it came positive for Mycobacterium tuberculosis. So at this point, it was thought that probably it is the uveitis secondary to tuberculosis, and the patient received treatment according to that, where the patient received antitubercular treatment and oral steroids for the next few months. 2 months later, this is what the fundus picture turned to in the right eye, where you can see that there is serious deterioration in the lesions that are in the fundus picture that is present, where the lesions have increased significantly. And this is the OCT, where we can see that the lesions that were seen before are much more prominent now, the sub-RP deposits that are present. And the vitrectomy that was done at this point was again subjected to cytology, and at this point of time, it was very clear that it was much more than inflammation. There was sheet of monomorphic cells that were present with extensive areas of necrosis. And CD20 was definitely very much positive here. And so this indeed, to begin with, was always a case of bilateral intraocular lymphoma, which got missed for almost 5 years. So if we go back and see where we could have avoided the misdiagnosis. So this is the first OCT that was probably the second OCT that was taken of the right eye the first time, and here we can clearly see that there are sub-RP deposits, which is very, very classic of a vitreoretinal lymphoma. So this is another classic picture. This is a different case, a classic picture of what a vitreoretinal lymphoma looks like, where you can see the creamy yellow deposits, and there would be areas of what looks like atrophy, which means that it is in different stages of the disease, where there is active disease and also there is inactive disease in certain areas. And here again, this is the OCT through the same retina, where we can see that here is the classic what we saw in the previous OCT as well, the sub-RP deposits. So whenever you see this picture, please note that this is a case of vitreoretinal lymphoma. And sometimes we could also see the vitreous cells, but not always. Sometimes the vitritis component, what looks like vitritis, it might be subtle, and it might just be the sub-RP deposits that might be present. So whenever this OCT image is seen, the diagnosis should always point towards intraocular lymphoma. And these respond very well with intravitreal chemotherapy if it is started on time, like in this case where we gave intravitreal chemotherapy to this patient and the patient did well. This is another case where again there is a yellowish, dirty yellow deposit that is present, and the brown pigment that is seen over it, which indicates the lipofuscin pigment that is present over the lesion. And this is the OCT image as I have shown previously as well. So again, you can see the classic sub-RP deposit, which indicates that it is intraocular lymphoma, and this patient again with intravitreal chemotherapy did well. There is of course some amount of fibrosis that is present, but tumor wise the patient did well. And this is another example where there is extensive intraocular lymphoma that is present, and again with the classic OCT image, and with intravitreal chemotherapy you can see the transformation where the lesions completely nicely disappeared, and of course it would leave behind some changes in the retina which would compromise the vision, but the patient is free of the disease. So intraocular lymphoma is one of the very commonly missed diagnoses. The reason that I put in more number of cases of that is that because it is commonly missed, but it is easy to diagnose if we look at the classic OCT findings in this case. Now moving to the second scenario, now this is a 65-year-old male who presented with diminution of vision in the right eye since 2 years. This is the fundus picture where we can see that there is definitely a subretinal lesion that is present, a melanotic lesion with lots of pigment that is present on the surface, the brown pigment, which is again the lipofuscin pigment that is present. And whenever we see a melanotic subretinal lesion, these are the differentials that we consider, including hemangioma, amelanotic melanoma, metastasis, granuloma, and lymphoma. Now let us look at if OCT can give us a clue and help us to narrow down the diagnosis. So this is the OCT image of the same lesion, and here we can see that the lesion, yes, it is a choroidal lesion where you can see that there is definitely the choroid is not looking normal, and there is a very irregular surface that is present. It is not like a smooth dome shaped elevation, but it is a very irregular surface that can be noted with of course the retinal changes as well. So whenever we see a very irregular thickening of the choroid on OCT, it rules out some of the diagnoses like hemangioma, melanoma, and granuloma, because these usually have dome shaped elevation and they are not irregular. Whenever it is irregular, it usually falls into these two categories. Either it is a case of metastasis or it is a case of lymphoma. So with this differential diagnosis, we did a whole body PET CT for this patient, and there was no tumor elsewhere in the body. And we did a choroidal biopsy, and this again had a sheet of monomorphic cells that are present, which was CD20 positive. So this was a case of choroidal lymphoma. So previously what I showed you was a vitreoretinal lymphoma, and this is a case of choroidal lymphoma. So intraocular lymphoma can be vitreoretinal or it can be choroidal. It's important to differentiate between the two because both of them behave very differently. The vitreoretinal, it mainly goes to the CNS and causes CNS lymphoma, while the choroidal lymphoma can have systemic lymphoma. So the way we investigate these patients is very different. If we see a case of choroidal lymphoma, we have to do a whole body PET CT to rule out that there is lymphoma elsewhere in the body. We have to do a bone marrow biopsy, which is not required if it is a case of vitreoretinal lymphoma. So whenever you see this is what we typically describe as a seasick or a rippled choroidal configuration, then it is a case of choroidal lymphoma. I'll end with this case. So this is a 52-year-old female. The reason that I'm getting a non-intraocular case here is because it is related to an intraocular pathology. This patient presented with a salmon pink patch. She already had undergone excision elsewhere. So obviously, as Savri has already shown, this was a case of conjunctival lymphoma with a salmon pink patch lesion. And she came with this histopathology report, which clearly said that it was a marginal zone lymphoma, and we completely agree with the diagnosis as well. She was fine for 18 months, for 1.5 years, and 1.5 years later, she complained of decreased vision in the right eye. Mind you that she had a lesion in the left eye on the conjunctiva, but she was complaining of decreased vision in the right eye. So when we looked into her fundus, now this is the fundus picture of the right eye, where you can see that again there is definitely some lesion that is present in the subretinal space, a very orangish yellow lesion that can be noted, and this is the OCT. This again, if you compare with the OCT that I showed before, this again has that very irregular seasick rippled choroidal configuration to it. This is very classic, as I mentioned, of either a choroidal metastasis or a choroidal lymphoma. Now in this case, and choroidal metastasis, it has a different kind of, it has a lumpy bumpy appearance. This rippled appearance is classically seen in choroidal lymphoma. So this patient in fact developed choroidal lymphoma in the opposite eye when she presented with conjunctival lymphoma on the other side. So it's very important that even if we are non-retinal specialists, we have to do fundus examination in these cases, because they have risk of developing choroidal lymphoma whenever they present with conjunctival lymphoma, so that we don't miss these, though it's rare, but it can still occur, and we should definitely look into the fundus as well. So with this, I end my talk. Thank you very much.
Thank you for the excellent talk, Dr. Swati.
So now I invite Dr. Vishal Raval, who will be talking about biopsy for intraocular lesions. So Vishal works along with me at LV Prasad Eye Institute at Hyderabad.
Good afternoon, one and all. Thanks, Swati, for the opportunity, and AIOS. The topic which is given to me is to elaborate on the role of biopsies, what we do for intraocular tumors. Yeah. Okay, thank you. I have no financial disclosures, so I think from the previous couple of talks you have come to know that mostly the cases what we see in our ocular oncology clinic, the diagnosis is kind of pretty much kind of straightforward. You see the clinical signs. Sometimes you need some kind of ancillary imaging modalities like OCT, B scan to confirm your diagnosis. However, in 10% of cases, the diagnosis is kind of challenging, or it can be masquerading. In that context, I think the role of biopsy is very, very important. And I think biopsy from the oncology perspective, it can be either diagnostic, whenever the diagnosis is kind of not straightforward, or it is kind of not mismatching or not going as per your timely management. It can be prognostic in few cases where you want to understand the nature of the tumor, whether any high risk features are there, so that you can predict any kind of future screening or surveillance for the patient. And sometimes the treatment itself can be the part of a biopsy, what we do. So these are the various types of biopsies which we usually do in our ocular oncology clinic, right starting from the needle biopsies, which can be done either transscleral or transvitreal. Vitreous biopsies, again, both we do in terms of rule out or ruling in kind of any infective or inflammatory, or sometimes any kind of intraocular lesions, and sometimes retinochoroidal biopsies also can be needed. The instruments, I think this is very, very important slide. I think before we plan for any biopsy, I think you need to be planning well ahead what all the instruments, what you need in your armamentarium, so that you are well prepared and there is no surprise on the table. So I think your 23 gauge trocars, your instrumentation, needles, flute cannula, scissors, I think all things should be kept in handy before we plan for any kind of biopsy. Coming to anterior segment biopsy, I think what we usually do is either in form of aqueous tap, or we can do any kind of iris or ciliary body lesions by using a needle or cutter based biopsies. And the indications usually are for any kind of iris lesions or any benign lesion like iris cyst or epithelial adenoma. Sometimes the diagnosis is not straightforward and you are kind of contemplating between a benign or a malignant lesion, and sometimes you can see some white fluffy seeds in the anterior chamber and you're not sure whether it is some kind of tumor which is masquerading in the anterior chamber. Aqueous tap, I think it is kind of straightforward. There is nothing to be known by how to do aqueous tap. You just use a 1 ml 30 gauge needle. You just put the needle into the AC, remove 0.1 to 0.2 ml of aqueous and send the material to the cytopathologist to understand the nature of the specimen. So this is one of the case which was a 58-year-old female who presented to the OPD with a kind of near total cataract. However, you could see there was a small amelanotic lesion which was residing behind the iris and it was pushing the iris in the front. There was a kind of small globular lesion seen in 4 o'clock to 7 o'clock lesion with kind of vascular malformity seen on the surface of the lesion. The ancillary imaging, as was shown in the previous presentation, we did, and it did show some kind of mass lesion usually arising from the choroid, and it was extending up to the ciliary body region as shown on the B scan. Looking at the morphology and clinical representation, a high index of suspicion for choroidal metastasis was kept in mind. The patient was advised for whole body PET CT scan, and to our surprise it came negative. And then we thought better to do a biopsy and to confirm the diagnosis exactly from what type of lesion it is and exactly whether it is a benign lesion or malignant lesion. And this is one short video. So what we do is just take your MVR blade, make a small puncture, and before you take the biopsy, fill the anterior chamber with visco. I think this is very, very important to prevent intraocular bleed. And you can use either 29 or 30 gauge needle and with back and forth movement, and the sister is kind of aspirating the material which you're collecting through the bevel of the needle. So the important pulse, I think one is to prevent intraocular bleeding. I think you should fill the anterior chamber with the visco so that you are able to get the biopsy material and not inadvertently any kind of blood which is mixed with the biopsy material. The diagnosis which was seen on cytology again was kind of a melanocytic tumor of origin, to confirm that we were dealing with some kind of choroidal lesion probably arising from the melanocytic origin. So we went ahead and did enucleation, and the diagnosis was confirmed to be amelanotic choroidal melanoma. Coming to posterior segment biopsies, again it can be either pre-equatorial or post-equatorial. For pre-equatorial lesions, we usually use the approach that is scleral, and any kind of lesion which is post-equatorial, the posterior pole, I think transvitreal approach is the best way which we do. For fine needle aspiration biopsies, I think the technique what we use is intravitreal technique, and it can be used either using your indirect ophthalmoscopy or your vitrectomy systems. So I will show a case. I think this was a 52-year-old female who again was diagnosed to have kind of amelanotic choroidal lesion, probably of tubercular origin. She was on 6 months of anti-tubercular treatment. However, there was no response to anti-tubercular treatment. All the investigations, at least ancillary imaging modality, showed it to be a kind of amelanotic variant of choroidal melanoma. However, the patient insisted on biopsy before going for any kind of plaque radiation treatment. So this is the video which shows where after 3 ports transscleral transvitreal biopsy, where we use a long 24 gauge needle which kinds of penetrates at the most prominent portion of the tumor, avoiding any major retinal blood vessels, and at the same time sister is kind of aspirating with 2 ml syringe attached to a short tubing, and this material is collected freshly and sent to the cytopathologist within 30 minutes of collection. In this, I think the important pearl is to increase the IOP whenever you're taking the biopsy, because there is high chance there might be bleed. So make sure that the intraocular pressure is around 60 millimeters of mercury. And again, to our confirmation of clinical diagnosis, the diagnosis was confirmed on histopathology to be melanocytic origin of cells and probably a melanotic choroidal melanoma. Both the histochemistry stains for melanin A and HMB45 positive. So sometimes we do needle biopsies again in case of melanocytic choroidal lesions, probably for prognostic purpose, particularly in case of choroidal melanoma, and it does helps us to plan for future surveillance testing, particularly when we look for any metastasis related to choroidal melanoma. Vitreous biopsy, I think this is what we do day in, day out for all of endophthalmitis or uveitic conditions. However, in cases which are not responding to your treatment, or you feel there is a high index of suspicion for intraocular lymphoma, then we go ahead and do vitreous biopsies. So this is one of the case which on clinical suspicion, it was looking very, very similar what Dr. SWATHI showed, case of primary vitreal lymphoma. On the OCT again, which was elaborated by SWATHI, you see the sub-RP infiltrates, and why we did biopsy. I think I come from a school of thought, unless and until I have the histopathology gold standard in my hand, I don't start any treatment. So I went ahead and did vitreous plus sub-RP biopsy. Usually we do only vitreous biopsies for intraocular lymphoma. However, from the initial papers from Shields as well as from few other multi-institutional studies, they have shown that if you take the biopsy from the sub-RP space, where actually the origin of the lymphoma cells is there. So this is the video which shows I have done the biopsy, both diluted as well as the undiluted specimen from the vitreous cavity. And for the sub-RP biopsy, what technique I used this small needle, which is directly entered into the sub-RP space, and I aspirate the sub-RP material directly from the area where the origin of the tumor cells is there. And the pearl, again, you need to collect specimen both in undiluted as well as diluted. And for the bevel, for the soft tip cannula, what I was using, always use a bevel cut at the distal end of the cannula, so that when you entered with that bevel, it easily enters into the sub-RP space. And this material is then sent for the biopsy. This again confirmed our diagnosis of diffuse large B-cell lymphoma with CD20 positive, and patient was started on intravitreal methotrexate regimen, close to 24 injections over a year. Sometimes we need to go ahead and do one more biopsy in advent related to vitreous sub-RP, and go ahead with retinochoroidal biopsy. And this is usually done in conditions where the patient is not responding to your treatment, or the fellow eye is threatened despite seemingly appropriate therapy. So this is one of the case which was diagnosed to a VKH, was treated for VKH in terms of oral steroids and immunosuppressants. However, the patient was not responding as per the clinician's discretion. They went ahead with the biopsy. At that time, they just showed reactive atypical cells. However, on the OCT, again, you could see there were multiple yellowish RP infiltrates, and there was a high index of suspicion for intraocular lymphoma. So we went ahead and did a repeat biopsy, and at this, because already vitreous was biopsy, there was no material which we could collect from the vitreous. So I went ahead and did a subretinal biopsy as well as retinochoroidal biopsy. So this is a short video where you can see I'm just selecting an area where clinically I know there is a high chunk of material particularly related to the lymphoma cells, and I am choosing an area which is very adjacent to an area where the normal retina is also there, so that when I send the specimen to the pathologist, it becomes easy for them to compare it with the normal retina. I usually use diathermy all around the lesions, 360 degree, and then with the chandelier illumination and bimanual technique, I use scissors and forceps to remove this layer of the retina as well as the underlying choroid. So always the pearl which is there, you always choose a normal adjacent retina so that the pathologist can compare with the atypical retinochoroidal layer, as well as you always use good diathermy to reduce any inadvertent choroidal bleed which can happen particularly when you do a retinochoroidal biopsy. Diagnosis was confirmed to be large B-cell lymphoma on histopathological examination. I will just go to the last part of my talk, which is excision biopsy. Sometimes we do remove the tumor in toto, which can itself be a therapeutic treatment for this intraocular tumors. So this is one of the case of retinal capillary hemangioblastoma. The diagnosis is straightforward. There is nothing you need any biopsy or anything for this. Systemic screening, again family screening, it was kind of very straightforward. However, you could see there was a multiple large retinal hemangioblastomas, particularly 2 in the temporal quadrant, and there was subretinal fibrosis as well as preretinal fibrosis and traction detachment. So considering the patient's one-night status, I went ahead and did en-block resection of the tumor, where after the core vitrectomy, a feeder vessel ligation was done, particularly to block the vessel which was supplying the feeder artery which was supplying the blood to the capillary hemangioma. After that, a good diathermy was done all around the tumor so as to prevent any inadvertent bleeding from the capillary hemangioblastoma. And then this tumor was excised in toto, which I can just show in the end. So yeah, so this is the tumor, how it was removed in toto from the tumor. And at the end, I think the patient did had a retina attached with silicone oil in tamponade. And this is last case. Again, this is a case of a congenital simple hematoma. The clinical diagnosis was very kind of straightforward. The OCT does shows the origin of the cells from the RPE. However, the patient had macular traction and decrease of vision over the 2 years. So the approach was simple. What we do for any macular hole surgery, we did core vitrectomy, induced PVD, and through bimanual technique, we did remove the tumor in toto and sent for histopathology, which confirmed the diagnosis to a congenital simple hematoma of retinal pigment epithelium. So I will like to give my concluding slide. So I think in ocular oncology, surgical biopsy still remains the gold standard of care because of its unique ability to provide tissue samples for direct histopathological analysis and also to bolster our diagnostic certainty. Appropriate surgical technique, careful tissue handling, and consultation with expert pathologist is very, very essential to reach to a confirmed diagnosis. Negative biopsy doesn't rule out any possibility of intraocular tumors, and if needed, need to go for a repeat biopsy. And multidisciplinary approach where your ophthalmologist, pathologist, and neuro-oncologist is the need of the hour. Thank you.
Thank you, Vishal. Thank you for the beautiful videos showing the various tumors. Now we have the last talk by Vijita. She'll be talking about the red flags in pediatric proptosis. Okay, by the time Vijita sets up, are there any questions from the audience for the previous speakers? Yes, Anirban.
Question. I think because of lack of time, I couldn't address that thing. I think usually we ask the pathologist to be in the operating room. If that is not possible because of the time when the surgery has been performed, I usually use, particularly for the lymphoma, if I am kind of doing a biopsy, I usually send a sample in equal proportion of 70% absolute alcohol. Yeah, that is the medium what I use for lymphomas. Otherwise, I think for your excision biopsies, I think your formalin should be enough to send a sample. But for lymphoma, I think 70% absolute alcohol is the medium which you should be using to send to a pathologist. If the pathologist cannot do on the same day, or you want to transport the medium to a pathologist who cannot take the specimen on the same day or cannot process on the same day.
Yeah, Vijita, please.
Good afternoon, everyone. I'll try to be quick. So over the next few minutes, we'll go through a brief overview of the causes of proptosis in children and identify some markers which would potentially herald some sinister etiology. So we all know that proptosis in a child can be as a result of infections, chorostomas or hematomas, vascular malformations, inflammations, primary neoplasm, metastatic lesions, or systemic leukemias and lymphomas. We'll be looking at case presentations which broadly cover the neoplastic and tumor-like conditions. So here's the first case scenario. 2-year-old girl presented with swelling in the left eye for about a month, and she had been treated as orbital cellulitis elsewhere with systemic antibiotics. However, the swelling progressed and she went on to develop proptosis in the last week. On reviewing the history, there was no history of trauma or upper respiratory tract infection, and this is the clinical picture that we see. There was a well-defined lower eyelid lesion along with abaxial proptosis, and superior globe dystopia. So, labeling a child with orbital cellulitis does not end it there. It's always important to identify the cause behind it. And whenever you cannot attribute it to a focus of infection such as eyelid infection or a style, it's very important to perform an imaging. So, the MRI in this child showed a well-defined lesion in the anterior and mid-orbit causing lobe indentation, and it pushed the orbital structures medially. The flag number 2 is that in a child presented with rapidly progressive proptosis with inflammatory signs, do not forget to rule out rhabdomyosarcoma. She did well with an excisional biopsy that confirmed the diagnosis as well, followed by chemotherapy and radiation. So, another child, a 5-year-old boy, presented with prominence of both eyes since 6 weeks associated with eyelid swelling. There were no other ocular or systemic symptoms. This is what we saw. There was bilateral mechanical ptosis and proptosis. And on imaging, there was ill-defined diffuse homogeneous isodense lesions in the superior orbit, which extended up to the apex. On systemic evaluation, there was low hemoglobin that was noted, but there was no reactive, there were no atypical cells in the peripheral smear. Interestingly, the incisional biopsy showed dense sclerosis and polyclonal inflammatory infiltrate, suggestive of a non-specific orbital inflammatory disease. So, in bilateral orbital lesions in a child, always rule out systemic causes through a thorough evaluation, and NSOID is a diagnosis of exclusion which can occur even in children. They usually tend to do well with steroids. The third case scenario is that of a 9-year-old girl who presented with a sudden onset swelling in the right eye which progressed over 1 week. She also gave history of generalized weakness and malaise. On clinical examination, there was gross proptosis with inferior dystopia. On imaging, there was a large, ill-defined, irregular lesion occupying the superior and lateral aspects of the right orbit in both intraconal and extraconal spaces. A scalloping of the orbital roof was also noted. So, a high index of suspicion was kept for leukemia, and peripheral blood smear, however, did not show any atypical cells. So, a debulking was performed, and the histopathology showed features of a malignant round cell tumor, which also showed FLI1 positivity. The bone marrow biopsy, along with the immunophenotyping, confirmed a diagnosis of T-cell acute lymphoblastic leukemia. She went on to do well with chemotherapy. So, in rapidly progressive orbital lesions in the presence of systemic symptoms, it's very crucial to rule out hematolymphoid malignancies. This can be done through a biopsy and with a peripheral blood smear and bone marrow biopsy. So, here's an interesting case of an 8-year-old child who presented to the emergency with sudden onset proptosis of the right eye and also accompanied by vision loss. He gave history of trivial trauma that could not be attributed. The vision in the right eye was hand movements. There was proptosis with inferior displacement of the globe, limitation of movements, and grade 2 RAPD. This was what the fundus picture showed with retinal edema and a central cherry red spot suggestive of central retinal artery occlusion. An ultrasound of the orbit showed a hypoechoic lesion with causing significant pressure on the globe and optic nerve. CT confirmed the presence of an orbital mass lesion. And in view of the central retinal artery occlusion, an ocular massage with IOP lowering therapy was administered, followed by a paracentesis. She was then taken up for orbitotomy, where the lesion was noted to be very irregular and non-encapsulated. On histopathology, there was a fibromuscular and fibrofatty background with proliferating blood vessels of various sizes lined by plump endothelial cells. And these endothelial cells stained positive for CD31. In the background, there were a lot of eosinophils, thus establishing a diagnosis of angiolymphoid hyperplasia with eosinophilia. On systemic evaluation, even peripheral blood eosinophilia was also noted. The proptosis resolved with oral steroids, but there was no improvement in vision. So, presence of loss of vision in a child with proptosis warrants immediate intervention. Vascular malformations are the ones which usually cause this picture, but any tumor, even benign ones, which can cause a mass effect, can result in vision loss. Now, a 5-year-old child presented with bulging of the right eye associated with pain, redness, and watering. He actually had an enlarged right eye, which was causing the pseudoproptosis, but there was no perception of light in the right eye. On a close examination, there was corneal clouding with hyphema in the anterior chamber and a fixed dilated pupil with a hazily seen cataractous lens. Since there was no view of the posterior segment, a B scan was done, which confirmed the presence of intraocular tumor with calcification suggestive of a retinoblastoma. MRI confirmed the presence of the same, and there was no extraocular extension. So this child underwent an enucleation with implant and adjuvant chemotherapy later on. Whenever there's no view of the posterior segment in a child with proptosis, a B scan is mandatory. It's important to remember that retinoblastoma can present as aseptic orbital cellulitis in advanced stages. Moving to the last case of this set. A 5-year-old child presented with protrusion of the right eye in 6 weeks, and there were no associated features. So there was inferior globe dystopia, and was the computed tomography showed there was an expansile lesion with the epicenter probably in the greater wing of sphenoid, but the lesion also involved the lesser wing and the body of sphenoid. There was also adjacent soft tissue involvement. That was not it. There was another expansile bony lesion involving the frontal bone with a small soft tissue component to it. So expansile bony lesions and with adjacent soft tissue components should point towards histiocytosis. In this child, the only parts that were involved were the skull. So an incisional biopsy was performed from the orbit to confirm the diagnosis along with a steroid injection. And she subsequently received chemotherapy because of the multifocal nature of the disease. So in lytic bone lesions, consider histiocytosis. Always evaluate to look more throughout the body, because presence of systemic involvement, all multifocal disease warrants chemotherapy. So I'll conclude by saying that tumors like RB and rhabdomyosarcoma can present like orbital cellulitis. Bilateral orbital involvement is seen in leukemias and NSOIDs. Systemic symptoms should alarm you for hematolymphoid tumors. Vision loss can be from optic nerve tumors or due to a mass effect. RB can also present as a painful blind eye. And in lytic lesions, think of histiocytosis. Thank you.
Thank you, Vijita. Sorry we had to rush you with your presentation. And thank you very much for being there. And sorry to the next speakers, we took extra 5 minutes.